is our platform. Welcome to our humble abode here at meetrx.com. I was told by Spencer that I've got to ask you about your project, and I want to ask you about your project. Let's just get a little few more people in here. Give them about 2 minutes to kind of join in.
Sure.
What'll happen is, Dave, so everybody's here, they'll be typing in questions, and I'm going to go and kind of read through as many of them as I can get to, and hopefully you'll be able to answer them. But we'll do a little by way of introduction. For you guys who don't know Dave, Dave has been a citizen scientist, biohacking, cholesterol genie, probably stuck himself more times than anybody in the history of the world, taking his own blood samples, and discovered that there's some interesting sort of variability around cholesterol, and it's kind of come up with this cholesterol energy hypothesis, and then it's kind of grown quite a bit from there. So, you know, one of the things that, so two things that I think, you know, I mean, I know they're going to get asked, so I'm just going to go ahead and ask them anyway, and then we'll see what kind of specific things come up. So, one is, I want to know about what you, Spencer, is it Tommy Wood as well involved in this little project? Maybe it's just you and Spencer, looking at, I thought it was like lean mass hyperresponders and CACs and CIMTs and things like that, but maybe you can elaborate on that. And then the other question that's always going to come up is, hey doc, I went on a carnivore keto diet and my LDL cholesterol shot up. Am I going to die? You know, this is, you know that. So let's answer the first question, the second one, then we'll go to the questions of the people here. And then maybe by way of just, for anyone that doesn't know Dave, maybe a 2-minute intro on who you are, Dave.
Sure. Just real quick, I'm actually a software entrepreneur and engineer by training. I've done fairly well in the technology space, and then I actually had left to go on a sabbatical for a couple of years and just like make games before going back to like a directorship position or starting a new startup or something along those lines. And in the course of doing that, went on a ketogenic diet. 7 months later, I get my blood tested and my cholesterol shot through the roof. And I flipped out because that's a normal reaction to seeing your cholesterol shoot through the roof. So I then go and get my, after I get that test, I then check in with my sister and my dad, who got inspired by me doing it and started doing it around the same time, but their cholesterol did not shoot through the roof. And so already I was thinking, this is kind of odd because of course they're genetically related to me. The one key difference is I am leaner and fitter than they are. And they would be okay with me saying that, by the way. But I then kind of got a little depressed for a couple of weeks, wanted to do a retest. And in the process of wanting to do the retest, I started learning everything I could about lipidology. And what I was stunned and excited to find was that actually, in many respects, the lipid system, the system that moves around cholesterol in your body, functions like a network, like the very things I've been working on really my whole life. There's really a lot of things in common. And then those 2 weeks later, that ended up being probably the big moment. I saw, even though I had been eating less saturated fat, less overall, my cholesterol skyrocketed further. It went up another 100 milligrams per deciliter. At that point, I may be the only person in history who saw an LDL of 300 and total cholesterol 400 and felt relief. Because I said, okay, there's definitely more to this story than what I've been kind of led to believe in. And I certainly was eating a lot less saturated fat. So sorry, it's a little bit more of a wind up, but that's kind of the gist of what got me started into then becoming obsessed with experimenting like crazy. I'm now up to 126 blood draws, I think, and some obscene amount of cardio check tests, because I've done something in the neighborhood of, I want to say 53, 54 experiments. Some of them, from a few hours up to a couple months. Probably the biggest known experiments are the ones that I do around the inversion pattern, where I actually eat more saturated fat, and that actually results in lower cholesterol, and that helps to supply more evidence towards the energy model. And conversely, probably the other really dramatic one that a lot of people know me for is the white bread experiment, because I wanted to emphasize that the quality of the food you go on to, if you decide to go low fat, high carb, is just not that relevant. It's relevant whether or not you're filling up your glycogen stores and whether or not you're adding, very high levels of insulin, and therefore, you know, removing a lot more of the lipoproteins from circulation and so forth. Anyway, so yes, I've been completely obsessed with that. I end up talking about cholesterol, and I end up talking about lipids a lot from the energy substrate standpoint, but I'm actually quite interested in things like proteins, you know, the amino acid pooling. There's really a lot that's interesting with saturated fats and the structural capability of cells. So we're used to thinking of fatty acids only from the context of the energy you can get from them. We almost never think about them in terms of, like, for example, Sean, you might be interested in this. Is there such a thing as conditional? What would we say with amino acids? Conditionally essential amino acids. There's like 8 or 9 of them, right? The question is there conditionally essential saturated fatty acids? And I'm very interested in finding out the answer to that question, because obviously we can make our own with palmitic acid. I'm very interested. Sorry, I think I just totally went off on a geek moment there, but these are all questions that I'm very interested in. This is kind of where I'm at the moment. So I kind of gave you the run up to where I'm at. This is where I'm at now.
So tell me about the thing with you've got going on with Spencer Nadolsky. What's the story?
Yeah, yes, okay. So I partnered with Spencer Nadolsky and Tommy Woods, pretty much the 3 of us. We're right now putting together a project, which I'm gonna kind of hint that we're right now looking at converting this into a study. And that is, I'm gonna say, as a technologist, I do get to points where I really want to pull all my hair out, because there really is a lot of procedural bureaucracy that kind of comes with trying to do a study that is not the land that I come from. The land that I come from is very results and agility, you know, defined and so forth. But whatever, I'm working with their process, right? We want to get a whole bunch of these people who not only have high LDL and total cholesterol like I did going on a low carb diet, but as I'll bet many people who are on this screen right now have observed, you see multiple things change over several different lipids. So there's total and LDL cholesterol typically going up. And I'll bet for carnivores, it's extremely common. You see HDL typically going up as well, the so-called good cholesterol. And you see triglycerides going down. Now there's a phenotype I like to call lean mass hyperresponders, and those have specific cut points. So LDL of 200 milligrams per deciliter or higher, HDL of 80 milligrams per deciliter or higher, and triglycerides of 70 or lower. And Sean, you know, as a doctor, actually all 3 of those metrics by themselves are very rare. It's extremely fascinating that we're in entirely new territory where that is not only a profile we're seeing commonly, but that it spans across all genders, ages, ethnicities. The engineer in me is kind of excited that it looks as if it may be a kind of mechanistic alignment of sorts once you become entirely powered by fat. Well, that group of people would of course be considered by conventional medicine to be extremely high risk. They forget whether or not their cardiometabolic markers across the board look great. The one of interest, the LDL being high, means that they are in danger. They're in trouble. They're going to be developing atherosclerosis, the buildup of plaque in the arteries, really fast, right? And so I've said, you know what, let's see if we can get funding for a study to make this happen. And for about 1.5 years before Low Carb Houston, I sought to get that behind the scenes, and I tried to engage with traditional lipidologists who I thought would just be champing at the bit to try to get a hold of this. And I was wrong. And so I did something that I still kind of can't believe I did. I went onto a stage in Low Carb Houston. I said, guys, just give money to me. Like, I'm going to try to crowdfund, raise this. And bear in mind, I come from the world where if you do a crowdfunding campaign for a product or a service where the backers will get that, right? Like they'll get a device out of it, or they'll get a concert or a movie or something like that, that it's already hugely a success if you can get to 50,000. That's usually the cap. If you can get to 50,000, that's a great campaign. Most will never ever see that. So I'm not only getting on the stage to say, hey, 50,000 is kind of like the floor. Like we need at least 50,000, because at 2,000 per lean mass hyperresponder, that would get us like 25. But actually, my dream would be for us to get to 200,000. That would give us what to me is a magic number. 100 lean mass hyperresponders. 100 people with extremely high LDL and extremely high HDL and extremely low triglycerides and otherwise good cardiovascular markers. That's going to be part of the inclusion criteria. And then let's see if the really high LDL creates atherosclerosis. That's the project in a nutshell. I'll just say that the way we're tracking this is we're going to be doing what's known as a CT angiogram at the beginning. You get an injection of contrast dye, and then we actually it's computed topography. Help me out, Sean. Tomography. Thank you. Basically, we're literally capturing the geography of the lumen of their vascular system, particularly the cardiovascular system. And if there is development of stenosis, if there's atheromas, et cetera, we're going to be able to see that at a higher resolution. And we've engaged with somebody who will be revealed eventually, who's a high-level luminary in this field in CT scans, but particularly because he's already ran a very large study himself. He's told us that actually the original follow-up time, which I was going to make 5 years, doesn't need to be 5 years. We should be able to see it in 1 year. We should be able to see in 1 year people with an LDL of 200 or higher showing a rapid rate of atherosclerosis. We should actually be able to see that in the CT scans, because again, this isn't events. You don't actually have to have a non-fatal MI or any of them. We should actually just see the geography change itself, because that's what we do see with those people who have the genetic disease of high levels of LDL, known as familial hypercholesterolemia.
I guess I'm surprised you guys, not surprised. I mean, obviously CT angiography is going to be the, I guess the gold standard for checking for that. It's just invasive, I guess,
Yeah, it is. I mean, let's face it, it's a call to science. I know it's kind of a big ask, because it's not just that they're getting it once, they're getting it twice. But what can I say? This is I would argue that the lean mass hyperresponder phenotype is basically a kind of gift to science, in the regard that up until this point in time, you go to the studies, you look at people that have high levels of LDL, and you're going to find the vast majority of them are looking at already sick populations. They already have atherogenic dyslipidemia, which is high levels of triglycerides yet low levels of HDL, along with the high LDL. They often have high inflammatory markers, high C-reactive protein, high TNF-alpha, high IL-6, and all of these other things that show that they're already in a chronic disease state. And the problem is that you start to learn about the process of inflammation, and you start to find that things like signaling molecules, such as cytokines, at a certain threshold will actually upregulate the total amount of LDL particles that the liver will put out into the vascular system. So already we have a temporality problem. We already have a cause-effect problem, in that we can't completely disentangle how much of those people who have higher LDL might have higher LDL as a downstream result of chronic inflammation. And that's a very big problem, because we should be able to look at those people at chronically low inflammation against having high LDL. And that just wasn't really that possible until now. That wasn't, for that matter, we also had the problem of healthy user bias. Healthy user bias was always going to be an issue on the epidemiology side, as well as those people are going to be a little more likely to have saturated fat, would also be more likely to smoke and to drink, and so on and so forth. So we now have a number of people who are wanting to be powered by saturated fat, but are also health conscious. I mean, Sean, you and I have just not had that in our lifetime, right? And so, yeah, anyway, that's all I'm saying is that's why we're so excited about this. We're actually really close to meeting our fundraising goal. We have an anonymous donor who's going to match us. So right now, everyone who's listening, if I haven't done a new fundraising push because I've been off filming this documentary, which I literally just got back from last night for 9 weeks. But we need to close the gap. There's about another, we've raised 75,000. We have another 25,000 to raise. And then once we reach 100,000, we have an anonymous donor who's going to match another 100,000. So at that point, we'll have the $200,000 goal. We'll be able to then get 100 lean mass type responders. We'll be golden. So that's, I probably should have wrapped with that part of the pitch upon saying this, but that's, once we get this data, I mean, it's going to take 1 year. 1 year from the moment we break ground. We could, in theory, have this data in hand in a year and a half, roughly. Like by the end of next year, we could actually have data that could really change how, I mean, at the barest of minimums, it'll open up this, hey, wait a sec, we can't look at the lipid hypothesis in this strict quantitative concept. At the minimum, we have to say, hey, wait a sec, there's this other context that if you're being powered by fat and that is the reason why you have higher levels of LDL, that perhaps that is not as deleterious or not deleterious at all. We don't know yet.
I did. This is, you kind of touched on this, Lewis, when you're talking about the lipidologist, but Stephen is asking, do you ever get frustrated that sort of the mainstream medical boards, I guess is what yours seems to ignore the experiments you've done so far? Is that a source of frustration for you?
You know, it's kind of fascinating to me because I've been going through, you know, my life is lived in two lanes. One lane is my citizen science lane. That's like going like this. It's going so fast. I can get experiments done and out and over and off to the races. And then there's this other lane that I have opened up and that I've been trying to work with academic partners. And they, I mean, Sean, I'm sure many people who are also on here who may be medical professionals who have worked in, you know, academia, they, God bless them. It's their process is just not the kind of process we tend to see in technology. In technology, man, you want to get to market as fast as you can. And if you've come up with a different product that brings new insights, you want to be, again, you want the rubber to meet the road as quickly as possible. You want to commit, meet deadlines, get that baby out. And that's not the world of academia. So yes, it will make a difference. I think it'll make a small difference once we have more stuff that are out there in papers to talk about the theory. But the biggest single bit of difference will be when we actually have hard data. When we actually have hard data, and that can go out in not only a publication, but then on top of that, you're going to have an existing community that brings that information back to their doctors. The bottom line is this: non-low carb, non-carnivore doctors are becoming aware of cholesterol code and my work and Siobhan's work and everybody who's been a part of, you know, helping to move this science forward. They become aware of us through you guys, through patients. And it's funny because the first patient, they go, that's just crazy talk. You're getting information from a blog. I don't care how rigorous they feel that they are with their so forth, with their, you know, information. But the problem is general practitioners pretty much have two channels of information. And they'll admit this. Well, I mean, I guess you could say three. Continuing medical education is supposed to be one of those, but it's not as influential. They'll concede that they get a lot of their study data from pharmaceutical reps. And I don't mean this to disparage pharmaceutical reps, but that is a primary means by which they get their, data, and also from patients. And to the degree that patients can bring them a compelling case for why it is that they may want to consider new opinions, that can have a big impact. And I think everybody should consider that. You look at people like Ted Naiman, you look at people like David Unwin, they all have stories on how there was a pivotal patient. There was one patient that, you know, cured all of these different problems, but on top of that had good explanations that made sense to them. It really started to crack open their thinking, and now they are who they are. The doctors are, you know, big advocates for bringing down refined carbohydrates and so forth, only after having this pivotal patient that started awakening them to this. So I feel like that's kind of how a lot of our information is getting spread now, and probably will be moving forward. I doubt that we're going to have a paper in which your office general practitioner is going to hear about us more than from the patients themselves.
Yeah, obviously the paradigm for how we get information is changing for sure. BNS is asking Dave, and I know you've done this challenge, is it true that no study has ever shown that high LDL is bad in the context of high HDL and low triglycerides? What's the resolution? Do we find anything that confirms or denies?
Yeah, so we have the challenge up. It's $1,000 finding fee if you can find, and it's not even high cardiovascular disease. Here's the challenge in a nutshell. The challenge is bring us a non-drug, non-gene study that shows those people who have high LDL alongside having high HDL and low triglycerides will see above average cardiovascular disease. Not even super crazy high, just above average, right? Otherwise, they have below average. And why would people with high LDL have below average cardiovascular disease in any context? And I think it's important to kind of circle this back to a great corollary, which is smoking. Smoking is dangerous. And I can say that with a lot of confidence, not because there's been a strong, massive RCT trial, but because I feel confident, given the amount of epidemiology that I've seen. It seems very compelling. Now, epidemiology is not great at proving causation. We can't say with confidence that smoking causes lung cancer in this, clear dose-dependent, process. But we can say its correlation with lung cancer is quite substantial. And then if you go a step further and look at it against all-cause mortality, I can say the following statement. I can say that there's no sizable group of cohorts that we've been able to look at where one of them smokes and one of them doesn't, where the one that smokes has lower all-cause mortality than the one that doesn't. And that's very relevant when we talk about LDL, because technically the existing lipid hypothesis is, I like this framing a little bit better. I think I want to start using this. It's a lipoprotein toxicity concept, as in it's the lipoproteins that are they're like smoke. The more you have, the worse it is. So there should not be any context in which high LDL won't result in greater all-cause mortality, and especially won't result in greater cardiovascular disease. So if there is one, then obviously we need to take a second look at how the hypothesis works. For that matter, better understand what those other things are that are higher on the list that have the greater association.
All right. Hey, Dave, somebody, Amanda Lee is asking us about coffee. What's been, I know you've tested coffee and I know it has an effect on triglycerides. What is the net effect of coffee on lipids? Do we have any concrete thing you can hang your hat on yet?
Yeah, so first of all, we're mainly looking at it in the context of higher than expected triglycerides for some people. And I'm sorry to tell you this seems to be particularly those with extraordinarily low levels of carbohydrate intake, which of course means it's disproportionately even higher among the carnivore community. The first and biggest thing to emphasize is that it's a fraction of the total. Most carnivores I know who are coffee drinkers don't observe this effect. But there is a fraction of those who observe the following. They get their lipid panel at their doctor, and they did properly do the water-only fasting, as we like to recommend, 12 to 14 hours. Please be aware that you really do want to be like 12 hours or longer water-only fasted. You can find more information on that at the site. But bottom line is you need to be sure that enough of the triglyceride cargo has been fully removed from your lipoproteins, and therefore you don't come up with a higher fasted triglyceride count. Again, everybody's working on a lower basal insulin level than most people on a mixed diet. So your doctor will frequently say things like, oh, hey, since you're in here anyway, let's just go and do a blood test. And you might want to say, well, I think because I'm on a very low carb diet, I'm worried that you'll see that my triglycerides are really high because I have less of a postprandial insulin spike typically than somebody on a mixed diet. And therefore the rate of removal from, like, say, the triglycerides in a postprandial state are going to be different. Maybe he won't understand any of that. But Point being is, I think you're better off having a fasted test. Now, again, that fraction of people who do get the 12 to 14 hours fasted, water only fasted, who still see their triglycerides being high, our next biggest suspect is that they have something we like to just call coffee sensitivity. And what that means is if you drink coffee, consider going off of it for like 10 days and then retesting. Now, when I've said consider going off coffee for 10 days, I've now come to realize I need to wear body armor and hopefully be behind protective glass, because apparently apparently coffee is a religion for many people. And it's like I've told them to turn against God and their faith and to start worshiping Satan. I have to be careful. I did not realize what that level of attachment is. But you can quit coffee for 10 days. It's worth finding this out, I think, if in fact you see higher levels of triglycerides. Now, the next obvious follow-up question is, okay, maybe we see higher levels of triglycerides, but is it bad? Now, to kind of get a little bit, first, the short answer. Short answer is I don't know. The bigger answer is yes, we have some threads in the groups and cholesterol code group and the lean mass hyperresponder group that talk about the different studies that show the many different ways in which coffee, uniquely coffee, not caffeine. People assume it's a caffeine thing. I assumed it was a caffeine thing, but we have people who have energy drinks, they have diet sodas with lots of caffeine, all that sort of stuff. They don't see the effect. Conversely, we have many people who have this coffee sensitivity and they have decaf coffee and they still see the effect. So it turns out there are some unique things about coffee. Actually, there's some very interesting stuff that Paul Saladino brings up that you guys may have already heard about. One of the more interesting recent things I found is that it's apparently an adenosine aggravator. And apparently this can also have an impact on your lipids. Part of the challenge for me is I don't want to do any experiments on it because I already don't like coffee. And I'm afraid that I develop a taste for coffee and then I would be a part of that religion. I don't want to be a part of any more religions. So that's where I kind of leave it for now.
All right, Dave, good. Jojo is asking, what do you know about hypothyroidism, potentially Hashimoto's and cholesterol? Does the thyroid, I'm sure the thyroid plays a role in there, but do you know anything?
For sure it does. Yeah. So first of all, I have to say, the thyroid is not really my wheelhouse per se as much. Siobhan is a little more up to speed on this one. I think, and you may have already gone through this before, Sean, I'm not sure, on how it's very common for people who are working at a higher rate of fatty acid turnover and less on the glucose side are going to, for example, see lower rates of T3. That's going to be pretty common on a blood test. And usually it's like just low range. I would consider the case of, more severe hypothyroidism as things that you would tend to see that are definitely well below range. But I think certainly the biggest key for me is whether or not that was in place before you'd gone on a lower carb diet so that you have a comparison to draw from. I don't know that we have a lot of data yet in a low carb context for where something would appear to be abnormally low, because unfortunately the data is just too new, and the thyroid does have relevance to the nature of the energy metabolism that you're working with, particularly when having turnover of fatty acids. It's a big part of, that aspect of it kind of comes back into the energy model. But one paper that I'm working through right now is potentially very relevant in that when your glycogen stores are really low, you have something known as hypoleptinemia, which of course just means very low levels of leptin in the blood. And that activates the HPA axis, which ultimately has greater white adipose tissue release of lipids, right? Particularly non-esterified fatty acids. The reason I'm taking you through this chain is that absolutely is having an impact on your thyroid homeostasis and the the hormones in play, it's a lot of engagement in the endocrine system in a very different configuration from what would otherwise be a mixed diet, or especially a carb-centric diet.
All right, so I'm going to, here's a comment from Dr. Phil Avedi, who's in the chat. Phil's a cardiothoracic surgeon. He says, I've learned more from cholesterol from Dave than I did in medical school in 15 years of practice as a cardiothoracic surgeon. So good job, Dave, on that. And Phil is one of the guys that's, for you guys that don't know, Phil has been essential in doing our research library here at MeatRx. We've got extensive hundreds and hundreds of studies we put up, but
well, that's very kind, Phil. Thank you.
Anyway, Dave, can you talk about the triglyceride HDL ratio? This is from Terry. Mine has gone from 4 to 0.8 on Carnivore. And I'm just going to add on there, how relevant do you think that is for predicting as a risk marker?
I don't like ratios generally because I feel like ratios can be misleading. I can tell you the cut points I like. I like HDL being 50 and above. I like triglycerides being 100 or below, if you're going to just hold me to something. Now, while I say that, I'm going to mention a couple caveats. One, triglycerides are very noisy. They're of the different things you're capturing on a lipid panel. They can jump up and down. Don't put too much stock into what your triglyceride levels are changing back around to. On HDL side, there can be genetic reasons for lower HDL, and we see from watching these patterns over time, a lot of people will, if they're coming from a metabolically deranged state, will have very low HDL for a while. That can precipitously get higher. We've seen that. And we've seen some people who have persistently low HDL that it appears to typically be more genetic in its context. But again, somewhat new information. The biggest key thing that I really keep an eye on is triglycerides. If triglycerides are low, this fits the energy model in that your body's having an easy enough time parking that energy substrate. Those triglycerides are making their way to the tissues successfully. And it's the reason why somebody had asked me this sort of provocatively on purpose recently. And this was my honest answer. I said, if I right now got to hire Sean Baker to be my personal trainer, and for 3 months I said, now make me miserable, but make me the leanest and fittest lean mass fat responder I could be. And 3 months later, my LDL was like 800. But I was very lean, I was very fit. And would I be worried about that? And the follow-up question I had is, I would say, okay, what's my HDL, what's my triglycerides? And if my HDL, my triglycerides would fall into place with what my expectation would be, which is in that context, I think my HDL would probably be in the 80s or 90s, given my existing patterns. And if my triglycerides were well below 100, and I suspect that they'd probably be below 80, then it would fit what my expectation of that profile would be, because I'm utilizing more of those fatty acids, and therefore they are having a higher turnover, and therefore there is less on a per particle basis, and therefore my triglycerides are lower. And that's why I like seeing just it in a context all by itself, triglycerides being low, and I like seeing HDL in a context all by itself being higher. The problem with ratios is you can get things like, say, a high triglyceride, very high HDL, which might look good. And it might not turn out to be good because it could be alcoholism, for example, right? Like you could have high HDL and coming onset of hypertriglyceridemia and think that you're in great shape because it's a 1 on the ratio, but turns out that it's not going to be. So like I said, I like those cut points a little bit better.
All right, here's another that's kind of still about energy, but a little bit different. I know you kind of touched on this. Is somebody saying, is Michael saying, have you ever seen A1C numbers go up instead of down for starting a carnivore diet? And I would assume that's, just put low carb.
Yes.
But yeah.
Yeah. Yes. And you know what? I want to address this because this actually kind of gets on my nerves to some degree. Sean, I wrote an article about you when you came back with high fasting glucose. And I posited then, and my opinion hasn't changed on this. So you probably hear the term adaptive glucose sparing a lot. Obviously, there's a little bit of a framing on it, and Amber O'Hearn brings this up, which I think is a fair point, which is that we may be framing it to where it sounds like it's a positive outcome when we don't know that for sure, right? But I can say this: the engineer in me loves homeostatic patterns. Love that. I love when you can strap a CGM to me and I can see an otherwise flat line. That to me looks good. I like that, particularly when I can see that there's a consistency from one day to the next, right? Because I tend to find that that already is one thing that provides some level of comfort of control. It doesn't mean that it's true, but it makes it more likely than not, right? So that's always a good starting place. So what I like to see is when there's consistently low fasting insulin, whatever the energy substrate is that are in the bloodstream to start with, along with there being that consistency with whatever those levels are. So do I think that Sean Baker, who like for whatever reason wants to work out 18 hours in a day, you know, he decides to break a world record in the morning, and then he's like, you know what, I feel like I could plug in another 2.5 on weights, that his body might go, let's go ahead and liberate more glucose each morning because he sure is pounding us over the course of the days and so forth. Yeah, I think so, because I, at a much lower scale, when I'm training for a half marathon, I find my fasting glucose climbs up in the morning. Now, do I think that there might be some pump priming? Yeah, I do. And not only that, I think I see also a window with my own self-experiments that seems to even suggest what that backward-facing perspective of time is. It seems to be about 3 days. The body seems to have, and again, this is somewhat anecdotal. I don't have a paper that I'm gonna write on it yet, but I definitely see lots of things. And this includes not just with the inversion pattern, but also with glucose. Surprisingly, with glucose, there seems to be an influence based on what my activity level, my exercise was in the last 3 days as to what the likelihood of my fasting glucose will be in the morning following. Here's where it gets exciting. Where it gets exciting is I don't see a clear change in, say, the insulin levels, to where I do see what seems to be a more distinct change in the glucose levels that are, you know, found upon my waking fasting glucose. So anyway, if your glucose levels are higher, your A1C is probably going to be higher. I know we could talk about the glycation and the lifespan of the hemoglobins and so on and so forth, but I don't think it's that. I think that, yes, you have higher levels of relative glucose than your sedentary friends who are utilizing more ketones relative to glucose and fatty acids on their own. So if you'll indulge me, John, I'm sorry, I'm probably getting a bit wordy on some of these things, but this one's kind of an important one to me, because this does kind of come back to the energy model, and I'm just gonna get just a little bit nuanced here for a second. The energy above the neck is going to be, you know, especially ketone driven, right? When you're low carb, the energy below the neck is cardiac muscle, skeletal muscle, they like fatty acids. We already have plenty of data that shows this, right? So if your body was smart enough to allocate as to which of the two channels it's leaning towards, it has a good reason to be leaning more towards ketone production when you're sedentary. Makes a lot of sense. And therefore, it likewise makes a lot of sense that your relative amount of tested ketones are going to tend to be higher, and that your glucose is going to tend to be lower. There's less reason for the glucose as well. Also, less fatty acid trafficking, relatively speaking. Still going to be trafficking a lot of fat. But relative to the person who's really fit, I don't think so. But let's change it. Let's say that you're actually working out a lot. You have more fatty acid trafficking. So less of the fatty acids in the liver are getting broken down into ketones, and instead are being packaged up with the triglycerides to go onto VLDL boats, and therefore higher LDL. And that's why it makes so much sense to me that we would find lean mass hyperresponders having relatively lower levels of beta hydroxybutyrate detected in the blood. And I suspect, Sean, we're also going to see relatively lower levels of acetone detected on the breath. Not because they're burning less fat. Quite the contrary. If we put them up to an RQ scale, we're going to find that they're burning plenty of fat. They're burning fatty acids, more fatty acids, less ketones, relatively speaking. That's important for the glucose sparing, because it then makes sense as to why it is that your body can be smart enough to say, I like all the energy that's going to get used down here at a relatively higher amount to be bioavailable, given what's been going on with this person recently, right? And conversely, if you're hanging out and you're, but this is why, Sean, I think I've said this to you before. If you ever get injured, you have to promise me that if for whatever reason you can't work out for a couple of weeks, you have to promise me, you guys are all watching, you have to promise, you have to get a blood test, because I speculate that we'll see changes in the metabolism similar to what I'm describing now. I'll bet your ketone levels would go up if you're eating roughly close to the same amount. And I'll bet your LDL in relative terms would go down. Not to, like, say a plant-based diet or something like that, but in relative terms to what it was from before that, I'll bet it would go down. If you were, we still have to get into basal metabolic rates and that kind of stuff. We're not going to, but I'm just going to say, I think that your panels would change. I'll just put it that way. I don't think that your lipid panel would look the same. I don't think your ketone levels would look the same, et cetera. Sorry, I hope you guys don't mind me totally going off on a tangent there, but that's I think that that's very relevant information.
Yeah, and you'll be happy to know, Dave, that I have a CGM sitting on my shelf over here that I'm going to strap on here. I'm just waiting for a few things to happen. I'm trying to get adapted to this new training workout I'm doing, and then I might play with that. Another question, it kind of goes back to the coffee one, and just maybe a quick comment on this. People ask, does it matter if it's caffeinated or not? Does decaf have the same effect as caffeinated coffee?
I have yet, so we have limited data. That's the bottom line. The one person we know who really went to town and did all of the caffeinated and decaffeinated found that they had the sensitivity either way. I haven't been closely monitoring the threads on that, but anybody is welcome to go to, I think the Lean Mass Hyperresponder Facebook group is the one that's probably explored the most of the two groups. You may want to check in on that thread. You could probably get that question better answered. If there's anybody else who's observed that, don't know that I've seen anybody. I'm pretty confident that would have bubbled up to me by now, but I could be wrong.
All right, somebody's asking about your current personal diet. I know you've done a carnivorous period of time. What are you at right now? I guess, can you comment on personal health with different varieties of diet? I know you're on the white bread, and I don't know, you do crazy stuff. So I don't know where you're at right now, Dave.
Yeah, well, so I really want a period of time where I can really just focus on my health. I've done a lot of experiments over the last few years. This is also why my own data is a bit confounded. I'm actually worried about when I next get a CT angiogram, just because I'm not a good case study of somebody who's just been strictly on a ketogenic diet. I've quite literally done things like the experiment where I gained weight on purpose to see what, would change. I mean, in order to gain weight, I had to become hyperinsulinemic. So did I, potentially create infarcts and so forth? That's all possible. That's all on the table. So it is true that I would love if there was a period of time where I could actually just focus on being on these, what I think would be very low inflammatory diets. And certainly carnivore is one of those, for which I would like to see longer term data in the way that I myself have collected. Like when I get blood tests, the blood tests I get, I don't even want to reveal out loud what they are, but they're very costly because I get something in the neighborhood of around 25 different markers. They're very wide spectrum. I don't just get things like C-reactive protein and CMP and so on. I'll get things like, say, leptin and glucagon alongside, fasting insulin and so forth, because I want to see how this data shakes out. And I think that would be good to see from, more people in the community. So yeah, I want to do that. Ironically, you'll find this amusing. Probably before that, at some point, there's some experiments that I need to do with the consumption of for some reason, not olive oil. Olive oil and fiber. Both experiments I'm not really looking forward to, but that I need to distinguish how it is that they impact lipids.
Dave, I know you, and I don't know if you're going to touch on this. I know you're talking about CT angiogram. Obviously, that's being the gold standard. But can you briefly talk about CAC, CIMT? Have you seen? I know in yourself you've observed shifts in your CIMT, and it's fairly dynamic, meaning that it occurs over a relatively brief period of time. Have you seen in the lean mass hyperresponder? I know Ivor's been tracking this, but have you yourself seen some improvements in either of those markers?
Yeah, so let's start with CAC. CAC, of course, is coronary artery calcification scan, and I think it's an excellent test. I think that if I had my druthers, I think that they recommend that you have it 50 and older or something like that. If I had my druthers with everybody, especially my own family and friends who are taking on, say, a ketogenic lifestyle or something very low carb, I'd want them to get it at the beginning to bookmark it, because one of the worst things that happens for us is that sometimes people come to us and they're like, I just got my first CAC. I've been doing this diet for 4 years and my CAC is through the roof. It's 400 or 500. And the problem is I have no idea of when that came about, how much it was their lifestyle before that, how much it was the last 4 years of their diet, etc. So I'm very much a fan of getting discrete periods of time for data, and then of course testing for that. Now, we've had some people who would say that they've held it steady, some who've said that it appears as though they've regressed it somewhat. We've had some people who have said that it's advanced. The catch is that there hasn't been really a lot of definitive data yet. I actually want to start a thread for where we can get at least stringing a lot of this anecdotal data together, because the downside is CAC is still relatively new to being accepted, much less relatively new for people to have multiple scans alongside having been on this diet. I mean, most people, understandably, if they have, say, high LDL and they see their very first CAC is, say above 100, or they find that they're in the 80th percent for their population, whether or not that calcification came before or after the diet is not really that relevant to them. They, again, understandably, they want to take whatever actions that they can help find to reduce their potential for risk. And then, it's one of those times in which people may consider other methods. Those people who decide, hey, I see that my CAC is this, I think it had more to do with the diet that I had before, but you know what, I'm going to hold out and find out for myself. I know a number of those people. I give the same caveat that I always do, which is, we're all in unknown territory. You've got to work with your doctor and best educate yourself for whatever it is that you decide that you want to do, but share your data either way. And let's, whatever you decide happens. And I think that's the right attitude, is we want to be sure that we can just get more data if we can. My gut right now is in that same place. I don't know. I don't know as far as CAC goes. Now, CIMT, real quick. CIMT I had been tracking very regularly. Then I had an experience, this was, I want to say, like last year, in which my tech was a little bit in a hurry. And while he was in a hurry, he kind of did my scan quickly, and then it seemed a little bit odd. After that happened, I insisted that we reschedule for a few days later. We rescheduled for a few days later, and the scan was very different from the one it was a few days earlier. And right then, I got a bit upset and took the steps to help acquire a butterfly that, like, Dr. Tro has, for example, and worked out an agreement. It's actually very convoluted. Worked out an agreement so that it was under our company and that we were leasing it to another doctor who is basically working with us so that it was all legal and that technically it was through them and so forth. And since then, I've actually done, this has been a little bit of a secret experiment, but I've actually been doing a lot of my own CIMTs to better kind of understand the process. And I've been comparing it with what others have had to determine for myself how much I do or do not like CIMT at the lower resolution level. The short answer is right now, I'm not sure that I do. I'm not sure that I like it as much if you don't have a higher level of quality assurance, I guess you could say. So I'm not sure if I would vouch for CIMT like I used to.
Yeah, I think that's a good point. Whenever I used to look at ultrasounds, I would, it's very tech dependent, and it's, I would certainly rather see something like a CAC, which has an algorithm that they do pretty much the same way every time, or at least they're supposed to, particularly if it's on the same machine. So,
unfortunately, we should address that because, alas, the capability of resolution for CACs has improved. The downside of that means that you could have the understanding that your calcification has increased when it turns out that it hadn't. It actually may have been the same, and then the resolution of the new machine this is why having machine parity is a big deal. Having tech parity is a big deal. We have to embrace what is in fact uncertain information and uncertain territory. And if there's really anything that I really want to get across to people is the value of doing high frequency testing, for me, has brought about the degree within the medical community for which things are assumed to be certain and fixed that are not. And so it's a bit frustrating, but one thing that I really want to be sure everyone that I can get across to everyone is be weary of taking any particular test and assuming that that's going to define your life. You should be comfortable getting follow-up tests. You should be comfortable getting follow-up opinions on the test that you've gotten. You really should want to get things from multiple sides. I think it's extremely important, and I think it's certainly one thing that's kind of come out of this. The CAC, unfortunately, is one of those. The CIMT, obviously, is one of those, and it's why there is value in high frequency testing where you can, where it's not, too much, say, radiation exposure and so forth, in that you can at least get a better sense of things like standard deviation and error rate and so forth at some level to better understand that.
Yeah, I think one of the biggest things that, you kind of help open my eyes to is the dynamic variability of, not only cholesterol, but so many lab tests are out there. I mean, this concept that, it's what's happening at that particular second, and 20 minutes later, it might be a very different picture. And we know that with glucose and some of the other things, but these things that we accept, we go in once a year to take a blood test, and it's like sticking your thermometer out in January and saying, well, that's what it's going to be the whole year. Let's wear a coat all year long. I mean, it's kind of craziness that we do this. Are there any other tests out there that might be good indicators of blood vessel health? I know there's these pulse, I don't know what they call it, pulse wave or something like that. There's new tests about every few years. But
yes. Flow mediated dilatation, is that like one you're thinking of?
Well, I don't know. It might have been that, but I mean, there's one where, I think it's a subcutaneous, it's a scan, maybe similar to an ultrasound, and it's done on the vessels, and it can talk about vascular health and age.
So be aware that most of the tests that come up and get a lot of buzz often fade back into the background. There's a lot of times this is the case with drug trials too. A lot of times there's a new device, there's a new treatment, and alongside that thing, there's a new study. And then the study is often in part conducted by those people who are funding, or who are stakeholders in the technology or the treatment or whatever. And you have to bear that in mind the whole way, because really until you have a lot of other studies that back up that initial study, it's hard for me to put a lot of faith in something that's new. There's one particular marker that I think if this is real, if they've really got it down, it's going to be a huge game changer. And it's the oxidized phospholipid test. Hold on a sec. So lipoproteins are the boats, and the boats are surrounded by phospholipids and free cholesterol, as are your cells. Your cells are made up of bilayers of phospholipids and free cholesterol, among other things that are on it as well. But that's the primary composition. Well, they have an oxidized LDL particle test. And I did an experiment last year where I speculated, and my experiment gave strong evidence to suggest this, that actually oxidized lipoproteins may not be that great of a marker because, as I suspected, they just track with lipoprotein levels. So when I was eating a lot less saturated fat, when I cut my food intake to half, my LDL particle went up per the inversion pattern. And as I hypothesized, so too did my ox LDL. So you have to ask yourself, did my cutting my food in half and therefore like half fasting, did I bring up the oxidative stress in my body? I don't think so. I don't think anybody would have likely assumed that. But that's because it's a pass or fail. Those LDL particles can be minimally modified. They can have minimal oxidation, and that's kind of like scratches on your car. You're still going to drive your car around because you don't care that there's some scratches on it, right? What we care about is if we see a lot of highly modified, highly damaged LDL particles, because I think that tends to be associated with an inflammatory environment. So if you're not counting the cars, but you're actually counting the damage, so you can actually count the number of oxidized phospholipids themselves, then you're counting a more accurate representation of the oxidation, the oxidized stress itself. And that, I think, will be super powerful because, and I know this would be somewhat controversial, I think it needs to be considered that it may be part of the job of LDL particles as part of the immune response to get modified, because you would rather they would get modified than, say, your cellular bilayers, which, for which there could be a chain oxidative event or something along those lines, which could be a lot worse, and for which you don't necessarily have scavenger receptors to deal with and so forth. Anyway, sorry, I went a bit bio-geeky there, but point being is that I do think that as new tests go, that's the one that I'm probably the most excited about. There's not really a lot else that I've been excited about, except if Sean, we finally get like home insulin tests, that's going to change everything. Much less a continuous insulin monitor would be awesome.
Yeah, I think so. I saw somebody talking about potentially getting a constant insulin. I saw some tech snippet about that. That's coming probably. So we'll probably get that in the next 3 to 5 years. I'm guessing something like that. Who knows? We'll have to see. Well, Dave, it's been an hour and it's been a pleasure. And I know everybody here has been very excited to have you on. Thank you for what you're doing, and thanks for coming on. Hopefully, we need to get you on our HBO podcast too. I know we kind of messed up on that, so we'll get you back on there as well. Maybe dive more into some of the specific topics. But thanks again, Dave. Hopefully, good luck with raising that last bit of money and get that study done. I know we got Spencer Nadalski's agreed to come on. I think next week or something like that. So we'll have the other part.
That's great.
And so. It's awesome to see you keep thriving and making a difference. And I hope you enjoyed the platform, and maybe we'll get you back on again sometime, Dave.
Thank you so much for having me on, Sean.
All right, guys. I'm going to end everybody, guys. You guys have a great day, and I'll see most of you guys tomorrow. We've got no guests on tomorrow, but then we have one on Sunday. All right, guys. Take care. See you guys later. Bye-bye.